Welcome to today's webinar, Providing Compassionate Support, Grief After Perinatal Loss. We're so glad you could join us. My name is Amy Gohl, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. A few pieces of housekeeping information before we get started. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Social workers must also complete a post-test. Within 1 hour after the webinar ends, you will receive an email containing the links to these documents. The email will be coming from me, Amy Gohl, at partnershipmch.org. Certificates of completion will be sent via email within 1 week. This program is being recorded and will be available on the partnership's YouTube channel until July 29th, 2022. We will be muting everybody's microphones during the presentation. We ask that you put questions in the question box, and at the end of her presentation, the speaker will respond to as many as possible as time permits. And now it's my great pleasure to introduce our speaker, Andrea Booker. Andrea is a nurse and the program manager for the partnership's Fetal Infant Mortality Review Program. In this role, she manages multidisciplinary case review teams and guides fetal and infant death examination and analysis of maternal interviews, social service records, and medical records. In addition, Andrea co-facilitates a perinatal loss support group. She is a frequent presenter on the topic of perinatal grief and professional support, and we are delighted to have her join us this afternoon. Welcome, Andrea.
Thank you, Amy. Good afternoon, everyone. I will be presenting today on providing compassionate support. It's a presentation on how to support the person after a loss. Before we get started, I just have to go over the few housekeeping details. This is just a little disclosure that we have. You have to just read over it really quick, and it's just if you have any conflicts of interest and about receiving your continuing education hours and programs for nursing or social work. So I'll give everybody just a second to read over that. At the conclusion of the program, the participants will self-report knowledge and related perinatal grief and support and intend to change the practice by including information or tools presented in professional practice. So this is the outcomes that we intend to achieve through this program. We'll start off with the definition of perinatal loss. Perinatal loss is a common occurrence which represents the death of an infant due to a miscarriage, termination, stillbirth, or neonatal death. There's different types of perinatal loss. Miscarriage is the first one, and it's an unintended termination of pregnancy prior to 20 weeks gestation. The most common type of pregnancy loss is miscarriage. About 15 to 27% of women aged 25 to 29, and that's increasing to 75% in women older than 45, if they're older than 45 years old, all have experienced a miscarriage. And miscarriage is also elevated if you have had a loss in the previous times in pregnancy. Stillbirth is another definition of a perinatal loss, and it's the definition of the stillbirth is a fetus under 20 weeks gestation and a birth weight with over 500 grams. In these cases, fetus has either died before or during labor. A termination is the use of an instrument or medical assistance or substance or any device to terminate the pregnancy. So a lot of women that have elective terminations due to fetal anomalies or a risk to the mother's health during pregnancy will experience a termination or a loss from termination. A neonatal loss is the death of a baby who was born alive and died shortly after birth. So neonatal can be up to 28 days after birth. So if you've died between 0 and 28 days, well, birth and 28 days is considered a neonatal loss. After 28 days, it's considered an infant loss. Neonatal losses happen for various reasons: prematurity, infection, defects of congenital of the organs or chromosomal abnormalities, or any other life-threatening conditions. Tragically, every year, 1 in 4 women experience a pregnancy or infant loss. In New Jersey, there's about 1,400 families experience this loss of pregnancy and infancy every year. The New Jersey Fetal and Infant Mortality Review is sponsored by the Partnership and Maternal Child Health of Northern New Jersey and the Department of Health. We try to research and better understand why these losses are happening. So that's where I come in with the FEMA program. It's the Fetal and Infant Mortality Review, where we review infant and fetal losses in New Jersey, and we try to figure out why these are happening, and we try to identify trends that are consistent along all the deaths and try to figure out why they're happening. In my next slide, I'm going to show you a short video of a woman who actually experienced an infant loss and collaborated with the partnership to create a video about her fetal loss and her son and how the partnership's FEMA program helped her. Okay, so that was Christine, and that was her video of her experience with her perinatal loss. And we work closely with her on other projects along with the partnership, continuing to advocate for this. The next thing we're going to talk about is the stages of grief. Grief can be categorized as the constellation of internal thoughts and feelings we have when somebody dies. Grief and mourning sometimes get interchanged, but they're very different. Mourning is when you take the grief you have on the inside and express it on the outside. So we're going to start off by explaining the stages of grief. They can go in any order, but this is the typical order that you would see the stages of grief: in denial, anger, bargaining, depression, and then acceptance. There can be short-term and long-term effects of grief, and you have to be able to, as a professional, determine how you can tell if somebody's grieving. So there's different ways. They may not always be upset or look upset. So you have to be able to identify the different ways that people express their grief. So we're going to go through. Denial is usually the first reaction to learning about the loss. Denial can also be interchanged with detachment. So they may detach from the situation, just not at all be paying attention, pretending it didn't happen. So denial and detachment can sort of be interchanged. A lot of times the person is saying this isn't happening, this can't be happening. And then we move into anger. Anger can be aimed at the inanimate objects or at the friends, family. It's all different times. They can even be angry with the dying or deceased child. Rationally, we all know that you can't blame the child for its own loss, but emotionally, however, you may resent the person for causing this pain or leaving you. So the person could present with anger. Bargaining is an attempt to regain control through a series of if-only statements. So some examples of some if-only statements that people would sometimes say would be, if only I sought medical attention sooner, or if only I got a second opinion. And it could be, if only I had eaten better, if only I had gotten more rest, if only I didn't go on that vacation. Any of those things could be an if only statement that the person is saying that could lead to you understanding that they're going through the stage of bargaining. They are somewhat making a deal with God or their higher power to postpone or get rid of the inevitable that is coming, that has already happened. So they're saying, if God, if you do this for me, I will never, if you let my baby live, I will never smoke again, or I'll never do whatever the negative thing is that they feel that they had done. They're going to bargain with God to change that. Depression, there's 2 types of depression associated with mourning. A reaction to practical implications and quiet preparation. So depression is definitely one of those things that looks different for everyone. So you'd have to really pay attention to the person and maybe know their normal or how they've been before and after the loss to notice if they were in depression. Sometimes people just Depression will show up as preoccupation with the loss. So they're just preoccupied with all the things that are going on, and they're not allowing themselves to feel the emotions. And then sometimes they're just in quiet preparation where they're not necessarily crying or physically upset or outwardly upset, but they're just saying their goodbyes internally, which may look quiet. They may be reserved, isolated, staying to themselves. And then we have acceptance. This is the phase where they have come to terms with the loss as much as you possibly can. Acceptance doesn't always look like they're happy or they're ready to go on with all the regular activities of their life, but it's a calm and a peace that comes with accepting what has happened. Bereaved parents never forget understanding, respect, and genuine warmth they receive from the caregivers, which can become as lasting and important as other memories of their life, loss, pregnancy, or their baby's brief life. This is a quote that I really love because as a nurse, sometimes you don't know what to say or what to do, and the person is very upset about their situation and their loss. But as a nurse, sometimes our impact can be as memorable as other things in their life. So I try to leave like a positive impact and a positive memory. So sometimes the positive memory can, go hand in hand with the negative memory. So you can have some good things to look back on. Even though it was a terrible time in their life, they could say, well, that nurse was really great and she really helped me, or that social worker was really supportive and they helped me through the process. As the FEMA program manager, I do a lot of chart reviews, and in the charts, so you'll read the social work notes or the nursing notes, and a lot of the mothers do say, this nurse really took the time out to help me, or the social worker really spent the time to find the funeral home for me, or do these different things that really stand out to them, and it really makes a bad situation better. The things that we can strive to do as caregivers and social workers and nurses when we're talking with a bereaved parent is just ensure privacy. That's number one. Whatever you're discussing, you want to make sure the person feels like they're in a safe and secure environment and that their privacy and their information isn't going to be compromised. Be genuine. I work with the Fetal and Infant Mortality Review, and I have not had the same shared experience. So I can't say I understand how you feel or any of these things because I don't, and I haven't had the shared experience. But I can be genuine. I'm a mom, and I can totally be empathetic enough to put myself in that situation and explain, that I can understand in some ways what they're going through, and I can just be there to support them and to help them in any way that I can. I'm not going to totally understand exactly what they're going through because I haven't had that same shared experience. And even if you had, everybody's experience is still different. So just be genuine, be authentic, and just be there for the person. This is one thing you have to really learn that's somewhat hard for me, is being comfortable with silence. A lot of times the person doesn't want to talk, they don't want to say anything. They may just need you to be there, or they may just need the family member or the caregiver or whoever just to be there, just hold their hand, give them a hug, allow for them to cry and just be emotional. They don't always need somebody to fix it. Sometimes they just need you to just be and be comfortable with them with the silence. Follow the parent's lead in terms of how they refer to the baby. So if they're referring to the baby by name, then you also want to refer to the baby by name. If they're just saying the baby, or you just kind of follow their lead on how they want to address the situation, how they're referring to the baby. Treat the baby and the family with dignity and respect. I know this is a big one that I hear from a lot of parents because, like I said, I read the medical records, and a lot of their complaints is that they didn't feel like people treated their baby that had passed with respect, and they didn't want to show them the baby, or they didn't want the parents to be too involved. And the parents were very upset about that. So they really do you have to really take into consideration of treating the baby with respect, even though the baby has passed. Remember to address them directly when you're dealing with fathers. Sometimes the fathers get left out of the picture. We focus a lot on the mother because she's the one who went through the labor or the delivery or the pregnancy, and the fathers kind of get left to the side. But fathers grieve also, and their grief may look different. But remember to address the fathers separately. Don't just group them in with the mother. If you're a social worker, you can have a separate session with the father, refer the father to male father support groups, and do things that are specifically for the father. And the father's grief may look very different. A lot of times you'll see men just try to stay busy. They may work more or do more things around the house just to distract from what has happened. These are common situations that you want to avoid. Don't assume anything. Just offer your support and let them know that they're there for you and be there to help them through their needs. They need to, make funeral arrangements or explain the loss to their older children or anything that they need, but just be there to offer your help and support, but don't assume anything. Don't ever put a timeline on grieving. Everybody's grief is different. You just have to listen, be there for them, be supportive, and take their lead as to how much help they want and how much help they don't want. Don't change the subject when mom starts to talk about her experience, because some mothers want to tell you everything, some mothers want to tell you nothing. I interview moms on a regular basis who've experienced the loss, and some are very open and they're very easily to talk to and they want to tell you all the details, and some moms give you short one-word answers, and you kind of have to pull some information. But don't change the subject, and even if she goes on about one subject and you're trying to get on to the next thing, try not to cut them off and try not to change the subject. Don't avoid the rest of the family. The family is there to support the mom, but they also are grieving. So they're trying to keep it together to be a support system for the mom, but the grandmother might be grieving, or the aunt, or the other children, or the father. So you also have to incorporate the family into the process. And don't say what's best for the parents. Like, for example, in the case of congenital anomalies or birth defects, some parents have to make the decision to do a therapeutic termination, or they have to decide whether or not they want to see the child who has severe birth defects. And those things, you can't really tell them what's best. Well, maybe it's better for you not to see the baby because the baby has a lot of malformations. You don't want to say that. You let them make that decision whether they want to see their child or what's best for them. Some things to remember: when people are in the stages of grief, everybody spends different amount of time in each phase. They may go through denial very quickly and spend a lot of time in depression, or vice versa. And you have to let everybody grieve at their own pace. There's no rules to how long you stay in each phase. And some mothers may be on and back to their regular routine in a week, and some may be years. And there's no right or wrong answer to that. Everybody expresses each phase with different levels of intensity. So I'm not very much a crier, but some people are extremely criers, and they're going to cry and they're going to be very outwardly upset. Some people are just going to be more calm and more inwardly upset. So everybody's phase is going to look different. The intensity is going to look different. Grieving is a very personal process. So there's no right or wrong way to grieve. You can offer your advice, you can offer your support, but at the end of the day, there's really no right or wrong way to grieve. And the 5 phases of grief don't always occur in order. So the order of the phases of grief could be, I could start in denial and then end up bargaining and then be in acceptance and then back to depression. There's no way to say this is exactly how it's going to go. Some people may skip phases and just go right into the next. So that's not going to look the same for everybody, and it's not going to occur in that exact order. The nurse or the social worker's actions can also be affected by their own value system. So make sure that you leave your own values out of the situation and try to just stick to the knowledge and the information that you learn as a nurse or a social worker. And the last thing I would say about things to remember was just that we as caregivers experience sometimes compassion fatigue, where your emotional and your physical exhaustion, and you're from being a caregiver and always having to empathize with people and feel their pain and compassion. So remember to take care of yourself, embrace your own spirituality, make sure you get adequate sleep, and do all these self-care techniques for yourself. Now, to give a little more detail into the FEMUR program, we use something called the cycle of improvement. The cycle of improvement is a model that we use in order to collect the data, review the cases, then we bring it forth to committees, and then the community action team will take that data and figure out ways to put forth initiatives in the community that help the process of fetal and infant mortality be reduced, and things that we can do to help educate moms. And then those changes, hopefully we'll see changes in systems and community systems. What the partnership is doing to help, the partnership for maternal child health of Northern New Jersey was a 3-state child and maternal health consortia, and they're licensed by the Department of Health and Senior Services, and they serve as the lead planning agency for the maternal and child health services in Northern New Jersey. Our mission is to meet healthcare needs of women, infants, and children in New Jersey while coordinating the education, outreach, and advocacy. So the partnership is joined in with the Department of Health, and the FEMA program is one of those grants where we help to change maternal and child health for the better. One of the partnership programs that I discussed was the Fetal and Infant Mortality Review. That's the program that I'm the manager of, and we do chart reviews. We take that data and we submit it to a case review team. The case review teams, we review the records and we pick out trends that are happening. So we sometimes notice like the parents weren't aware of fetal movement. So then we see that happening over a lot of cases and we say, okay, that's a trend. And then we escalate those trends to the community action team, which then takes those trends and they will put together actions that help reduce the risk of those things. We also have the Perinatal Mood Disorders Initiative. That initiative helps with postpartum depression and any other perinatal mood disorders. They follow up with parents who've experienced a loss and parents who haven't, and they just go over postpartum depression symptoms, and they refer people to the appropriate resources. We also I do collaborate with Life After 2 Losses, and I facilitate or co-facilitate a pregnancy and infant loss support group. The pregnancy and infant loss support group is open to mothers and fathers, and we have different topics every month, but we focus on perinatal loss and people who've experienced perinatal loss, miscarriage, stillbirth, any of the types of perinatal loss. These are two of the resources that all the parents that participate in the FEMA program's maternal interviews receive. And it's the After Your Loss brochure, which contains a lot of resources broken down by county of the information as to where they can see support groups and different resources for loss, funeral home information, and all things loss. And it's broken down by county. So this is a good resource to use as a nurse or a social worker when the parents need information. And then we also give this book, Tender Hearts, Tough Decisions, which helps like what happens next after your loss. These are some of the resources that we use and some of the other things that we do. The Star Legacy Foundation and different loss after attachment theory. And the goal is not to serve the parents' bond with the deceased baby, but to help integrate the deceased baby into their lives and their social networks. So thank you all for listening to my presentation today on bereavement and perinatal loss. This is all my contact information. If anybody has any further questions or if you want access to any of the information or any of the resources that I described. And after this, Amy, I guess we'll ask questions, or she'll take the questions from the chat box and we'll answer some questions.
Great. Thank you, Andrea, for that very interesting presentation. We have just want to remind everybody who's on the line that if you do have questions, to please enter them into the question box at this time. A few questions have already come in, so we'll get started. The first question is, New Jersey accounts for nearly 6% of all fetal deaths. What is driving that number?
Okay, well, as of 2017, New Jersey's infant mortality rate is 4.5, which is below the national target average of 6.0. But the New Jersey struggles in many categories of our prenatal and infant mortality rate. So the categories that New Jersey struggles the most are no prenatal care makes up for 1.5% of our total people that have no prenatal care. But our African American moms that don't receive prenatal care is at 4%. And the Black infant mortality rate is 9.4%, which is over the national average of 6%. So those are things that drive New Jersey's numbers down. like up, I should say, that make New Jersey 6% of the losses and the mortality rate. And low birth weight, prenatal care, preterm births, and low risk C-section rates in New Jersey would need to be improved.
Andrea, Amy lost her videos, sorry, her audio, so I'll ask some other questions that have come in from the panelists.
Okay.
We've had a few attendees ask if they, how they can obtain copies of the brochures and booklets that you posted as part of your presentation.
Anybody that would like some can just email me. My email should be up on the screen. And I have a PDF version of the After Your Loss brochure that I can send them. And if they need like print copies of the books, they can just let me know and I'll be able to send out like print copies.
Great, thank you. Another question from Sharon says, a feeling that mothers often express after a loss is guilt. I should have done X, or I shouldn't have done Y, and then they blame themselves for the death. How best to address that guilt?
I think when addressing the guilt is kind of using medical knowledge to kind of maybe disprove the guilt. So sometimes if they say, I shouldn't have ate tomatoes, you know, you can explain to them that tomatoes doesn't necessarily have an effect on the child's health, or this, like a lot of times the parents aren't told exactly why their baby died. Because I'll sometimes interview parents and I'll ask them before I review the chart, like, did they tell you why your baby passed or what happened, or did you have any problems during your pregnancy? And they'll say no. And then I'll review the medical record and they'll have a lot of things that was going on during their pregnancy, or there was a obvious reason as to why the baby passed. And sometimes when they know the reason as to what happened, they don't blame themselves for things that weren't the reason. So sometimes finding out the reason is helpful, and sometimes just helping them like discredit these thoughts that aren't accurate.
Andrea, Amy is still experiencing technical difficulties. She should be back with us in just a moment.
Okay.
If we could all just stand by. Here's one. Is it possible to mention that I think this is pronounced Nahama Comfort, is available to help with all needs for Jewish families who experience infant or pregnancy loss?
Oh, yes. Well, Nahama Comfort is one of the organizations that we definitely work well with. The community action team that we have together, one of the members is Reva Judas, and she's on the community action team, and she helps with Nahama Comfort, which is an organization that helps Jewish women after their loss. So they help them with like funeral arrangements and all their religious requirements after their loss, and anything that's within their culture that they need support on after a loss. Nahama Comfort is a great organization that helps with that. So if you have any Jewish women that are in your that you work with, or anybody that works with, Nahama Comfort is a great resource for them. If anybody wants more information on that, they can also just email me and I can email them more information about that. If there's somebody on the line from Nahama Comfort, if they're able to just put their information in the chat box also.
Actually, Reva is the one who posted the question.
Okay.
This is Amy. Can you hear me?
Yes.
Yes, Amy.
Oh, I'm
Wonderful.
back. Sorry, I'm still down, but that's great. We can have audio contact. I don't know which questions you've already gone to, but I have a few more here. Is it all right if I start asking?
Yes,
Go ahead,
that's
Amy.
perfect.
Okay. So what support is offered to the fathers of babies?
Well, for the fathers, we do have the Perinatal Loss Support Group that I co-facilitate. We meet every third Thursday via Zoom. The information for that support group is on the partnership website, and that's open to mothers and fathers. The Star Legacy Foundation also has support groups and information that's open for fathers. And while the fathers are in the hospital, the social workers should have separate resources for fathers and counseling information for fathers separately.
Thank you. Are there any correlations between income and infant loss?
Well, sort of. The infant mortality rate is highest among mothers living in poverty compared to those in middle and high incomes. But so yes, but the unmarried mothers, the infant mortality rate is over 70%. So you could say if you're unmarried, you have more than likely less income than two-parent home, and higher. So the unmarried mothers is higher, and people living in poverty is higher. But you can't directly only correlate that to income, because if you're in poverty, you also have like less access to healthcare and less resources, less family support. Probably you're further away from healthcare. So there's all of these other factors, less likely to enter prenatal care early. So yes, income plays a factor in all of those roles, but all of those things fall under not having a higher income.
In the same vein, Andrea, could you speak a little bit about racial disparity and infant loss?
Yes, like I said, in New Jersey, our infant mortality rate right now is 4.5, but our Black and African American infant mortality rate is 9.4. So definitely there's a disparity in the infant mortality rate amongst whites and Blacks. A lot of that correlates with a lot of different factors. Like we said, income. A lot of the African American women are in like lower income brackets. It also has to do with implicit bias, which is like the biases that healthcare providers have towards different nationalities and races. So a lot of times, sometimes income doesn't play a factor, because an African American woman in a high income bracket and a low income bracket will also have the same mortality rate. So it's not always an income thing when it comes to race. So sometimes the race is affected by different things. But there's a lot of times in different states and cities in New Jersey, the counties that have higher infant mortality rate are more of the African American population. So there is definitely a correlation that African Americans have a higher infant mortality rate than their white counterparts. But there's a lot of factors that go under why that is.
Thank you. Is there a correlation between the number of children a mother has and infant death?
Yes, but the higher mortality rate is related to factors that's not because of like her health, because of she had a lot of children, but they're related to other factors, such as like the second or the child after the third child, they usually have earlier weaning, so they'll stop breastfeeding earlier, which can cause higher infant mortality rates. They have reduced care for the infant because they have other children to deal with, and those reasons that people with a lot more number of children have a higher infant mortality rate. It's not health reasons, but it's just that the parents usually choose to stop breastfeeding sooner, so they're not getting the same amount of time and care and energy, and they have reduced care. As you get multiple children, you're just busier, and there's less care focused on each child.
What's the most important thing that we can be doing in healthcare to prevent infant mortality?
I feel like the most important thing we can be doing in healthcare is educating the parents on the main important topics, which are prenatal care, early entry to prenatal care, because that's a big reducing factor in infant mortality if you enter prenatal care early. Birth spacing, which I don't think a lot of people get a lot of education on birth spacing. It's best to wait at least between 6 to 18 months in between pregnancies. The recommended is 18 months in between pregnancies. And then minimizing elective C-sections. If you have a C-section, you have a 50% higher chance of your next child being born preterm. So they're trying to reduce elective C-sections and low risk C-sections rates so try to more vaginal births basically, and even VBACs. And then prematurity prevention. That's another partnership program also, is preventing prematurity, because a lot of times people aren't aware they may have like incompetent cervix or different medical conditions that cause them to have preterm births, and they're not educated on things that they can do going forward on the next pregnancy, or not smoking, not being around secondhand smoke, a lot of things that cause premature deliveries, that they can reduce their risk of fetal or infant mortality by doing prematurity prevention education. So education on those main topics.
Thank you. Thank you so much. I have a question about how can we get some of the brochures that you mentioned?
If my email address should be on the screen. The After Your Loss brochure, I have it in a PDF, so I can email that to anybody who would like it. We do have print copies. It's a slight delay on the print copies, only because our offices are closed and I don't have as many on hand. But I will be going in the office on and off, so I'll be able to grab some. So if anybody needs the actual print copies of the books, I will be able to get that out to them. Just email me. But we do have a PDF version of the After Your Loss brochure, so you can get that one immediately.
Thank you, Andrea. Here's another question. What should a professional do if they have somebody who's had a loss? How do they get referred to the FEMA program?
Well, there's a form that all the hospitals have, and it's called the FEMA referral form. Most of the time it's completed by a nurse or a nurse manager, but it could be completed by anybody, social worker, nurse, anybody in the that was involved with the patient's care. And it basically gives me the name of the mother, the infant's name, the medical record number, and like the date of their loss. If you don't have any of those forms, anybody can email me if their hospital doesn't have that, and I can give it to them. But I usually receive those from the hospital, and then I take those forms and I will contact the mothers and work on like extracting their medical data. I also receive referrals from the postpartum depression program. So if your hospital refers somebody to the postpartum depression program that also experienced a loss, they will then refer that person to me after.
And then could you talk a little bit about what the interview is like in the parent's home?
Yes. Well, there's two types of interviews that we're doing. One is over the phone, and it's like a short 15 questions that I just get a brief overview of their experience. I ask them about their prenatal care. How was it? I ask them about their experience in the hospital. I ask them if they're like back to work. How are they doing physically? How are they doing emotionally? I ask them if they know any of the reasons, like complications during their pregnancy or any medical conditions that they had, and if they know why their baby passed. So I go through that brief interview. If the person elects to do the full interview, it takes about 2 hours, sometimes 2.5 hours. And it goes through detail by detail, their whole entire experience from conception to birth, or to, the loss. And then we go detailed into what they ate, what they did, where they were, their financial information, if they're married, if they're single, if they have other people living in their household. Every detail about what they did or didn't get during their prenatal care, what they did or didn't get during their hospital stay. And it takes about 2.5 hours. And I sit down with the mothers. Fathers are welcome also, or significant other companions. Everybody's like welcome to participate. The more people that participate, actually better. You get more perspectives of the situation, because sometimes like what the mother says is different experience than what the father experienced. So it's good when you have the whole family participating. And that one takes about 2 hours. Right now, we're not doing them in the home in person because of the COVID, but we are doing them on either GoToWebinar, or GoToMeeting or Zoom, or just over the phone for 2 hours.
Thank you. I think Laura has a couple of questions that have come into her. Do you want to ask your questions, Laura?
Yes, thank you, Amy. We have a couple of questions. The first is, I am a nurse home visitor. I have a mom who experienced a neonatal loss in November 2019. She is pregnant again now. Do you have any tips for how to deal with this scenario?
I think the best thing to do when they're on their second, like life after loss, is to just keep them informed on all the options, like of what they can get and what they can do to help prevent whatever happened the last time. Normally, if they're on their second loss, like if they have experienced a loss and that they're on their second pregnancy, they should be referred to like an MFM and be seeing like different specialists to follow their pregnancy more closely. And I think just being supportive, because, you know, if you're a mom who's experienced a loss, it's hard to enjoy your second pregnancy because you're constantly worried about something happening again. So just teaching them, you know, stress relieving techniques and deep breathing exercises and ways to kind of combat those negative thoughts, along with seeking extra medical attention, making sure they're asking all the right questions to their provider, making sure they're being referred to higher levels of care if needed, depending on what caused their loss the first time.
Thank you. The next question is a comment that says, it's also helpful to just confirm that many people have the same feeling, that it's their fault, even if it isn't true. Just knowing the feeling is common can help.
Yes, yes, that's one of the benefits of support groups, is to see that other people have experienced what you've experienced. So you're not just out there by yourself and you're just feeling like, oh my God, is it just me? When you attend a support group, it helps you to really understand, like, there's other people going through this. I'm not the only one. It's not wrong for me to feel this way. It's not wrong for me to be upset. These are the normal feelings that people are feeling when they experience this. So attending a support group is one of the main ways to help people understand they're not alone in this.
Thank you. Here's another question. When speaking to families who have experienced a perinatal loss, what were some things they found helpful or comforting while they were in the hospital?
Well, one of the main things I think that people feel helpful when they're in the hospital is the nurses or the social workers coming up with a plan of what they're going to do with the baby afterwards. Like, a lot of people, there's a lot of options as to what you can do with your baby, even if the baby passed. So, like, you're allowed to still do skin to skin. You're allowed to bathe your baby. You're allowed to have to see your baby or not see your baby. You're allowed to do pictures. There's a lot of things that you're allowed to do with their baby, even if you have a loss. So a lot of parents who know this ahead of time, if they know that they have a fetal demise and they know they're going to deliver a stillborn, they work this plan out ahead of time if they would like to still do skin to skin, or if they would still like pictures, and if they don't know and the baby's born and then the baby dies shortly after, just helping them understand that these options are available, because they are good for helping them grieve. And a lot of parents who've experienced a good process afterwards are usually, that's the good experience that they convey to me. Bad experience is like, oh, they took my baby to the morgue and I never saw them. Nobody explained to me what happened. Nobody let me see my baby. I didn't know. You know, I found out later that I was allowed to bathe my baby or I was allowed to do these things, and they didn't know. So I think what I hear the most that they appreciate is when they know what they are to expect with the loss and what they're allowed to do with their baby after.
Thank you, Andrea. Here's another question about the details. In a hospital setting, when you care for a mom with a fetal demise, there is a lot of paperwork involved. Have patients expressed when it is appropriate time to go over those items, such as an autopsy?
No, I don't think that the patients will really express when it's appropriate. I think that's kind of the nurse or the social worker has to kind of read the cues of the patient to see if they're in a good space where they're able to do that. You know, some things like the autopsy has to be kind of asked right away. Do they want or not want the autopsy? But if they had an autopsy or something, or there was genetics done, and do they want to know the results? That's something that can come later. So it's more the social worker, the nurse really just have to read the body language and the social cues as to if the parent is ready for this information. As medical professionals, we all know there's a lot of paperwork and things have to get done. But I think you have to just gauge on your own, like, the best time and place to do that. Some things it's easier maybe to do with the social worker. The nurse and the social worker can collaborate on maybe the social worker asking the patient a few questions and seeing where they're at, and then telling the nurse, okay, I think it's a good time for you to go and ask them, or ask them to sign the paperwork or not. But it's really an individual thing. Some parents are fine and they're signing everything right away. And then some parents are completely distraught and they just can't bring themselves to make a funeral arrangement or sign a form or anything. So it kind of has to just be a case-by-case basis. And even discharge time is a case-by-case basis. So sometimes the social work will speak to the patient on the first day and they might not get discharged till 3 days later. And the 3 days later may be when you have to ask them about the funeral arrangements or signing some forms, because that initial day, it's just too difficult for them.
Thank you. I think we have time for a few more questions, and I want to mention that there has been a good amount of information coming in from Riva about Nahama in terms of how to contact the support line and what services and are available. So I'll read that at the end, and I'll just ask a few more questions that have come in until then. One is related to breastfeeding. Are there any protective factors related to breastfeeding when it comes to infant mortality?
Yes, they do say breastfed babies have a least likely chance of a less likely chance of infant mortality. The health benefits of breastfeeding, because where the first few days of breast milk is colostrum, which has a lot of antibodies and immunities from the mother that get passed on to the baby. And so that's one reason why it reduces the infant mortality rate. And it also, the mothers are usually closer with their babies more often. So they're going to experience the connections and the, more care, closer care and watch over the baby. So breastfeeding definitely reduces, like breastfed babies have a lower rate of infant mortality than non-breastfed babies. Yes.
Thank you. So there's, this question is about hospital policies. Do you gather information about hospital policies to support parents after loss?
Yes, like to some extent, our goal is not to blame or point fingers at the hospital. So we don't try to like dig into, did the hospital do something wrong or not? But if we see something that's a policy that could be helpful for us to just gather more information, we do look more into it. For example, one of the things that I'm working on currently is making some kind of standardized system or some type of timeline as to when the autopsy reports have to be added to the medical records. Because sometimes I'll review the medical records months out and the autopsy reports are not attached to the medical record. So the autopsy information could be very helpful for information on the fetal and infant, like mortality, why the babies are passing and different things. So we're trying to get hospitals to more standardize the process of attaching the autopsy to the chart in a timely fashion. Another hospital policy that I'm kind of working with right now is a drug screen. There's no standardized procedure as to when a hospital does a drug screen. So some parents come into labor and delivery with a fetal demise or with like any type of high risk pregnancy or high risk delivery, and some are given a drug screen and some are not. And there's not really a standardized process across the board as to when or they should or should not do a drug screen. And that also could be helpful information into determining what's causing the fetal and infant death. So we're trying to see if there's some type of standardization of a drug screen that we can like promote or propose or find out what's going on with that. So those are two like semi-hospital policies that I'm currently working on. So yes, we do try to look into hospital policies when we see things that could be helpful.
Great, thank you. So we have just a few more minutes, and I'd like to inform the attendees that information about Nahama, including the hotline number, is posted in the chat box and sent to all attendees. Perhaps, Andrea, after the presentation is over, if there is another way to present that information to the attendees in an email or some other form, that would be helpful.
Yes, if anybody wants information, more information on Nahama Comfort, just email me. My email should be on the screen and I will get that right out to you. and get you in connection with whoever you need to speak to.
Okay. I think there's just one last question, and this person is asking for your thoughts on this. There was a time that I baptized a baby that was stillborn and the mother was very upset. I learned a lot from this experience. What are your thoughts about this?
I can definitely understand that. A lot of the parents choose or don't choose pastoral care. That's something I definitely see in a lot of the cases. Some people, it's like a must. They want the blessing of the sick and they want the baby baptized. Some parents are either non-religious or just not wanting that at the time, and they don't want it. So, I mean, I think a lot of the things that you can do with the baby is very much up to the parent, and it's a very much an individual decision. So asking the parents ahead of time, like, these are your options. You can see the pastoral care, you can have the baby baptized, you can have the blessing of the sick, you can have photos of your baby, you can bathe your baby, you can do skin to skin, you can do all these things that the option is out there, and then let the parents choose what they want to have and not have. Because if we choose for them, they may be upset. So it's kind of like just, and if we don't tell them at all that they had the option, they may be upset that was an option that they didn't do. So just giving them all the options of what your facility allows and letting them choose.
Thank you, Andrea and Laura. I have one more question on this end. Andrea, how can a professional get involved in some of the work that FEMA is doing?
Well, we are always looking for members of our community action team, which is made up of professionals and consumers and bereaved parents. Anyone can be on. And also our case review teams, which is usually made up of professionals, nurses, doctors, social work. So that panel also is where we review the cases and we go over the information and try to identify the trends. So we are always looking for members on either. If you're a professional, you want to be on the case review teams, you can always send me an email with your information and a resume. If you are a professional or a consumer or a bereaved parent or an outside organization that deals with perinatal or infant loss and you'd like to be on the community action team, you can also send me an email and a short resume and we can talk about you joining that one. But we're always wanting people to join. We always need members because we have 2 meetings a quarter. So every 3 months we have a case review team meeting, and then twice a year we have community action team meeting. But in between all the meetings, we're always working on projects and doing different things. So we always need support. We always need members.
That's great. And as somebody who's been involved with the committees for a number of years, they're great learning experiences, and you can be involved with a lot of very worthwhile projects. Well, I think that's all we have time for today. I'd like to thank Andrea for a wonderful presentation and for answering all of the questions. And to Laura Hall, who wore 2 hats, not only running the back end of the program, but I appreciate her assistance as the co-facilitator for this program. Great job. A reminder to everybody who has joined us for the webinar that in under an hour, you'll receive an email from me. It'll have a link to the the post-program evaluation. Please fill those out. Certificates will be sent within a week to the email that you provide on the evaluation. A calendar of the partnership's upcoming virtual programs can be found at www.partnershipmch.org under the Professional Education tab. We also offer on-demand recordings of many of our programs. They're also listed on the website. Our Thursday webinar series continues with the next 3 weeks devoted to World Breastfeeding Month related topics. As an added bonus, next week on August 5th, we will be having a webinar on mental health needs of children during COVID-19. I hope you can join us. Have a good rest of the afternoon.